A lot of the old thought when there was an issue with the uterus, whether it was bleeding, fibroids, pain, was, well, just remove it. Actually, that's an old thought. Let's talk about all the new thoughts, all the different options someone has, because there are a lot of really important factors to consider. Welcome back. My name is Eric Schmidt. I'm a board-certified OBGYN, minimally invasive gynecologic surgeon. We're going to be talking about the importance of the uterus and why we try and recommend options to try and preserve and save it if somebody is having an issue. And really, the hallmark of a good treatment option is that you're trying to have a combination of alleviating the problem, least invasive way, with the least amount of side effects. And so we're going to be talking about a number of different topics, issues in this video, and hopefully we can give you the best option. And why don't we say just remove the uterus? I don't need it anymore. Well, there's a lot of things and a lot of reasons why someone might want to retain or keep their uterus as we try and fix the issue that's going on. Number one, well, hormonal function is tied in with the uterus from the ovaries. While the uterus itself doesn't necessarily have a significant hormonal function that contributes, it is intimately connected with the ovaries. And so let's draw a diagram. All right, so again, the uterus muscle itself here, ovaries on each side, red showing the blood flow to the ovaries from the body's side wall would be over on each of these sides. And so if we're do the hysterectomy, we do have to go through one of the blood supplies to the ovary to remove the uterus, no matter how we do the hysterectomy. And so while it may not completely disrupt someone's hormone function, it does potentially impact it to some degree. And we're learning more and more about this. Studies are showing that the hormone function, even if someone keeps their uterus, may go down slightly, potentially becoming symptomatic, potentially putting someone maybe at a little bit more increased risk as estrogen goes low sooner than it should. Also, some studies showed that maybe someone, instead of going through menopause age 51, 52, if they have a hysterectomy, even if they keep their ovaries, they may go through menopause potentially a year or two, maybe even a little bit more sooner based on lab tests. Doesn't necessarily mean that they're more symptomatic if they have this, but that's at least what the lab and following things like FSH showed. Also, another reason why someone would want to keep their uterus is that the top of the vagina and the cervix, often with a total hysterectomy, will be removed. Even if somebody has a partial hysterectomy, meaning keeping the cervix in place, there is still some potential nerve issue if somebody gets a lot of positive sensation from intercourse from their cervix being in place. And this varies a lot between the individuals. I always try and explain to patients, know this about yourself. If you get a lot of the positive sensation from that area, let your doctor know if you're talking about treatment options for an issue, and because that might play into which option is best for you. And the third reason, and one that varies a lot between people and patients that I see, is what the organ of the uterus means to the individual person, how it makes them feel as a person. And so removing it can potentially significantly impact that for some people. And so keeping these three things in mind, why we shouldn't just pull the trigger and always say, well, just give me a hysterectomy. All right, this is hopefully the good part of the video where we're talking about the different issues we discussed in the previous video. We'll put a little card in here if you haven't seen that one yet. But the different causes of abnormal bleeding, we talked about structural causes. Those could be things like polyps within the endometrial cavity, like here. And so one of the best ways to take care of things like polyps or a fibroid that's called submucosal, meaning it's more on the inside lining versus in the muscle or on the outside lining, is with hysteroscopy. And so we would take a very thin camera, thinner than this pen here, and it would go up through your cervix up there, and we would be able to resect that issue pretty easily. Quick, easy procedure, 20 minutes in and out. Often a lot of people do it under anesthesia, but you have options to do it in office at some locations with just some outpatient anesthesia. You could also try and treat the main symptom of these things, which would likely be bleeding, with medications too. That could be, we'll call that meds. That could be things like hormonal medications to help regulate the bleeding, or tranexamic acid, which is a newer medication we're using for people with heavy menstrual bleeding, could help control the bleeding from polyps or submucosal fibroids. But generally, the standard of care for something like this would be hysteroscopy, because it's so quick, easy, minimal disruption going forward, back to your normal day and activity within a day or two after it. Okay, let's talk about, fibroids more in depth, because these would be fibroids within the muscle here or on the outside. And if someone is suspected to have fibroids that are leading to issues like bleeding or pain, there are a number of different uterine sparing options that we can do. This would be things like, first off, medications, just like we talked about. We'll call those meds. There's both hormonal and non-hormonal options to help control the bleeding associated with fibroids. Unfortunately, there's no medications that's really going to make a fibroid significantly shrink or go away. And those medications, again, would include both hormonal and, we'll say, non-hormonal options. There are also some potential newer medications that help to work to regulate and that would be like GnRH medications that potentially might help somebody with fibroids, potentially shrink them a tiny bit, or help control the bleeding associated with them. Now we're going to be talking about more procedures or surgeries to help alleviate the symptoms and keep the uterus. This would be things like uterine artery embolization. This is a procedure done most often by radiology or interventional radiology doctors, where they have a catheter, just like the one that would go to the heart to help alleviate blockages. They have a catheter that can go in the artery of the leg, snake up to the artery of the uterus, and try and block the blood flow to a specific fibroid. Now, there are some potential limitations to this option, such as how big is a fibroid? Is it just one fibroid? It's good for that. But if somebody is having like multiple fibroids, significant amount of fibroids throughout the uterus, it's not so good for that. And fibroid size, generally less than 7 centimeters, is kind of an accepted norm for most of the radiology departments that I've seen that do this procedure. We'll talk about this option, comparing it to the ones that I'm about to talk about more in depth in future videos, so stay tuned. A newer procedure would be an ablation procedure. There's two types of ablations that we can do to help treat the symptoms of uterine fibroids. There is the endometrial ablation. That would be the ablation that's done with hysteroscopy. Just like how you would resect a polyp or fibroid previously, you'd have a camera that would go up inside the uterus, and it would you take the polyp fibroid out that way, and then what you do is you burn this lining here and help control the main symptom of bleeding. Now, this can work for people that just generally have bleeding with no cause, that's not precancer or cancer, or if somebody has smaller fibroids, like 3 centimeters or less, this generally can work well. But if someone has significantly large fibroids, generally this is not a great option for them. Which leads us to the next option, which would be laparoscopic ablation or radiofrequency ablation of fibroids. So there's actually two versions of the radiofrequency ablation of specific fibroids, laparoscopic and hysteroscopic. I only have experience with the laparoscopic. That procedure is called Accessa. It's a nice little procedure where someone would just get 3 small incisions on the belly, and then you go in and you use a little probe that you would insert into a fibroid. That probe heats up, it burns that fibroid, and it kind of, for lack of a better way to say it, destroys that fibroid from the inside kind of instantaneously. Now, it's not a perfect fix. It's not going to make the fibroids go away, but what initial studies are showing is that there's a significant 50% reduction in that fibroid size. Also, potentially 50% reduction in the symptoms like bleeding or bulk type symptoms, or dysmenorrhea that somebody's having from their fibroids. Now, one of the best ways to potentially alleviate the symptoms of the fibroids is to remove them altogether. This is done with a procedure called myomectomy. Myomectomy is a great procedure to completely remove the fibroid, but what you do have to do is often, I'm doing my myomectomies laparoscopically, and so with doing that, if we have a fibroid that's, say, decent in size sitting here top of the uterus, there is overlying muscle of the uterus from that fibroid. We do have to cut through that muscle, kind of shell out that fibroid and take it out that way. And then once we get that fibroid out, we have to sew the uterus back together. So the uterus will have more scar associated with it from a procedure like a myomectomy, which often, if that scar is significant, we might be recommending for future pregnancies that someone may have like a C-section delivery. But this is one of the best ways to completely remove the fibroid and hopefully get rid of the bleeding symptom. Definitely get rid of those bulk type symptoms that can be caused by large fibroids. But this is good for really any size fibroid. The ablation, the excessa that I talked about just previously, I didn't mention, but often fibroids bigger than 7 to 10 centimeters isn't a great option for that type of way of dealing with fibroids. This isn't an all-inclusive list of the different options. It's just some of the main options that you may encounter and talk to your doctor about if you are suffering from fibroids and the symptoms you're having. And of course, these options, all someone would retain or save their uterus, which the alternative potentially, or the ultimate fix for fibroids would be to remove the uterus with a hysterectomy. But that's not this video. Kind of the last broad topic that we're going to talk about, because we're not going to really talk about necessarily the precancer and cancer, because that is kind of way different in how you would approach it, but is ovulatory dysfunction. I spelled it wrong. So you might hear your doctor potentially say that the hormones are off that's causing the potential bleeding abnormality. And so when we're working up somebody that has a bleeding issue, if we're not seeing something like fibroids, polyps, submucosal, an ovulatory dysfunction would kind of be in the same category as something like PCOS, where the hormone signal to the uterus is just off by a little bit, and that can have a kind of a drastic effect. Some people may bleed for weeks potentially, maybe even longer. Because that, again, the hormonal communication to the uterus is just off, and so somebody is, has heavy, longer cycles. Dog. Again, just like before, there's medication options, and so very similar. There's hormonal type medications that can help give a consistent signal to the uterus, so that the bleeding irregularities are less, hopefully gone. A non-hormonal option, TXA, for somebody that's having heavier bleeding. I think we need a whole video to talk about tranexamic acid, because I feel like I'm mentioning it a lot, but not fully explaining it. I'll make a whole video on it. And something that certainly has earned its own video is if somebody is looking for a longer-term fix for their bleeding irregularities, not looking for pregnancy now, potentially not at all, is a big decision that we're often having with patients that want a good fix for their bleeding, is something like an IUD or something like an endometrial ablation. So specifically, these are the hormonal IUDs. Again, IUDs definitely aren't right for everybody. And so I think that's a misconception, is that we try and push them on everybody, but no, they're definitely not right for everybody, but they work really well for a lot of people. They don't work well for some people, but an IUD can be a great option to help manage somebody's bleeding long term. Same with endometrial ablation. If somebody is looking for a non-hormonal long-term fix, and let's say they're having these bleeding irregularities due to perimenopause, age 45 or older, and they're just trying to get through to menopause, but they're just having all these irregularities because of the inconsistent ovulation from perimenopause, endometrial ablation might be a perfect option for them, and it's non-hormonal, which is always nice. Again, least chance of potential side effects. There are some other downsides to endometrial ablation. We'll talk about that in its own video when we compare endometrial ablation, which will hopefully be coming out very soon. Now, was this a completely all-inclusive video talking about the treatment options that someone has? No, but it was a great kind of general what direction you can head to help save or retain the uterus while treating the main symptoms that might be going on. And so hope you enjoyed this video. A lot of videos coming up comparing the different options in the very near future. Hope you have a great day.